Hello, I'm Dr. Collins, and in the statistics video we'll explore the confusing screening tables and we'll therefore have a closer look at the terminologies sensitivity, specificity, and positive and negative predictive values. Understanding screening tables is crucial because they help clinicians, researchers, and public health professionals evaluate the real-world effectiveness of diagnostic and screening tests. So in this video, we'll break down these terminologies and explore easy and memorable ways of working out screening table calculations, both for exam purposes, but truly understanding the screening tables and the meaning of these terminologies will also help you better explain the limitations of the investigations we request. Alright, our first step will be filling out our 2x2 matrix. In every screening table, you will have an area for the test results, which can be either positive or negative, and a disease area where patients will either have the disease or not have the disease. When the patients have the disease and they test positive for the disease, this is called true positive. Makes sense, doesn't it? The patient has the condition and the test has correctly identified this. So this is great. The flip side of this is when the patients who do not have the disease are correctly identified by the test as not having the disease. In other words, true negatives, which also have great value. The patients who are not sick are identified as not sick, so we can stop worrying about these patients and reassure them. Now, the whole reason why we need these screening tables is the two other options, the two other possibilities that lie in between these very straightforward optimal possibilities we just discussed. Because most tests are unfortunately not 100% accurate, and there will often be some patients who fall in these two other categories that you need to be very acutely aware of, as these are the patients who suffer from the limitations of the investigations and screening tests. The most worrying one for me is when the patients who have the disease incorrectly receive a negative test result. This is called false negative, which can be very dangerous, and this is why it is very important to use tests that are least likely to miss out these patients, because these are the patients who will be reassured by the fact that their test result is negative, whereas in reality they are sick. The final possibility, which is not as terrible as the false negative option, but still not an ideal situation, is when some participants who do not have the disease will incorrectly test positive for the disease, which is called false positive. And these are the patients who will unnecessarily be put through a lot of apprehension and possibly will have further invasive tests because they don't have the disease, but the test is suggesting that they do. The best way forward in exploring the screening tables further is to make this topic a bit more practical with an example question. So here's an example. Let's work through it. Let's say we're given a question in which a study is being conducted that is evaluating a new tool, a new investigation that rapidly screens for colorectal cancer. You've got a total of 50 patients in this study at this phase of the clinical trials, and you find out 47 of these 50 patients indeed have the disease with the gold standard colonoscopy. So the total number of participants who actually have the disease is 47. And we're also told by the stem of the question that of these 47 patients who have positive colonoscopy, 43 of them tested positive for the colorectal cancer using the new screening tool. So these are our true positives. 43 patients have the disease as proven by the gold standard colonoscopy, and they also tested positive for the disease with the screening tool. Now, taking it from here, we need to fill out some parts of this table ourselves. The questions for screening tables may not always give you a fully worked out table to start with. You may need to fill in some of the numbers yourself. So, a quick math here, 47 minus 43 is 4. In other words, 4 patients who do have the disease is falsely testing negative for the disease. So these are our false negatives. Another quick calculation here is if we have 50 patients in total and 47 of them indeed have the disease, that means we're left with 3 participants who actually don't have the disease. We get also informed by the question that these remaining 3 participants who had negative colonoscopy also tested negative for the colorectal disease with the new screening tool. So this means that these 3 results are all true negatives, which is great because it means that there are 0 false positives. There are no participants who received an incorrect positive test result. Now that we filled out our table, the questions that you will come across from this point onwards will likely ask you one of 4 things. What is the sensitivity, the specificity, the positive or the negative predictive value of this new screening test? Now we're going to look into how to calculate these specific values. And there are 2 ways you can go about it. You can either use the traditional gold standard method, which is basically properly learning what each of these specific terminologies, values really mean, and thereby you can deduce these values from the table yourself. And I strongly encourage this method because it relies on reasoning rather than memorizing, and it gives you a good feel of what these terminologies actually represent for the accuracy of the investigations and the tests. Or you can use the shortcut arrow method, which we will come on to in a minute. Let's first explore what each of these terminologies mean and how you can use their meaning to help you guide how to calculate them. Sensitivity is the proportion of patients with the disease, so we're looking at all of these patients, who have a positive test result. So you would divide your true positives with all the patients who actually have the disease. True positives plus false negatives. Specificity, on the other hand, is the proportion of patients without the disease who have a negative test result. In other words, you divide all your true negatives with the total number of patients who do not have the disease. Please note how both sensitivity and specificity used presence or absence of the disease as their common denominators. Because when it comes to positive and negative predictive values, we're going to turn things around a little bit and we're going to look at the presence of a positive test result or a negative test result as the common denominator. So here we go. Positive predictive value looks at the proportion of positive test results, so all of them, that are correct. So in other words, you divide your true positives with all the patients who has a positive test result. And similarly, negative predictive value looks at the proportion of negative test results that are correct. So you divide your true negatives with all of the patients that have a negative test result. Now, going back to our second way of calculating things using the arrow method, it is as following. For this method, you simplify things and give each segment a letter, A, B, C, and D. Then you remember these terminologies with the following analogies. Now, being overly sensitive in life can make things go downhill very rapidly. So you're thinking of A divided by A plus C, but being specific on the other hand is a very good characteristic that often lift things up. So D divided by D plus B. Now we're left with horizontal lines, obviously, and with positive predictive value, you're going to think of the 2x2 table as a graph, and you're going to want to go to positive values on the x-axis. So A divided by A plus B. And what goes around comes back around. The negative predictive value go towards the negative values on the x-axis. So D divided by D plus C. Alright, we're nearly there. Now, all we have to do is to put those numbers into the formulas we just talked about and calculate our sensitivity, specificity, positive and negative predictive values. So let's do one together. Remember, sensitivity is the proportion of patients with the disease who have a positive test result. So in other words, you divide your true positives with all the patients who have the disease, true positives plus false negatives. And if you're using the arrow method, you remember that being very sensitive may make things go downhill. So A divided by A plus C. And whichever method you're using, you end up dividing 43 by 47 and you get a result of about 91%. So that is our sensitivity. I would encourage you to stop the video here and work out the remaining calculations yourself for practice. But here they come now, spoiler alert, the worked out answers. We got a specificity and positive predictive value of 100% and a negative predictive value of 43%. Now, at this point, I think we should take a step back and think what these values mean for our new screening test. Do we think that this is a good screening test? So overall, these numbers mean that this new screening test is very reliable for confirming disease due to its perfect specificity and positive predictive values. However, it is unreliable for ruling out disease because of its low negative predictive value, because a negative test result does not confidently indicate the absence of the condition. So, in other words, this new screening test is excellent for confirmatory purposes. However, it should not be used alone to exclude disease, and negative results should be followed by further testing or clinical evaluation. Thanks for watching. If you like this video, hit like button and subscribe, and don't forget to check out our other statistics videos. And if you'd like some practice questions, visit our website. Take care. Good luck.